Hi everyone, welcome back to class today. We are going to start in looking at different healthcare systems across the world today. And today we're going to go through the Beveridge model. The Beveridge model is chapter 16 of your textbook. The title of the chapter is The Beveridge Model, Nationalized Healthcare. So to help you kind of appreciate the different healthcare systems that are used around the world, what I'm going to do for each of the next few chapters is give you a little bit of a history lesson so you can see what current events at the time prompted these healthcare systems to kind of come out of it. So I'm going to start with background for the Beveridge model. The first important thing to note is that in the aftermath of World War II, the Labour Party came to power in the UK. So just think a little bit about kind of the end of World War II and what the UK was looking like at that time. The UK was very heavily involved in World War II. They were bombed a lot. And so when the United Kingdom was coming out of World War II, the country, it was a little bit tattered and war-torn. And so this idea of kind of solidarity between countrymen was very prevalent in the UK around that time. So when the Labour Party came to power after World War II, the Labour Party based its domestic agenda on a plan that was laid out by an economist, and the economist's name was William Beveridge. William Beveridge laid out his plan while World War II was going on. So the name of the plan was the Report of the Interdepartmental Committee on Social Insurance and Allied Services. And this plan that the economists kind of laid out during the war outlined a new social compact that was defined by shared sacrifice and this notion of solidarity between countrymen. So just kind of think about how this fit in with kind of the context. So during World War II, again, UK, they were kind of they had a hard time during World War II. Like they won the war, but at the end of the day, they kind of came out of it pretty bruised. And so during the war, when the economist was kind of creating this domestic plan, unsurprisingly, the flavor of the plan was everyone kind of needs to rally together and stick with each other. So after the war, when the Labour Party came to power and they were trying to figure out what their political agenda was going to look like, they adopted this plan that Beveridge had basically written during the war. So the healthcare system that eventually grew out of Beveridge's plan had three defining features. So these are going to be the three features that kind of characterize different countries of the world that use the Beveridge model. It was named after the economist William Beveridge. And although the countries that use the Beveridge model around the world vary slightly in terms of kind of how they implement this plan, these three features are kind of the defining characteristics of how the Beveridge model looks for the countries that are utilizing this kind of healthcare system. So feature number one of the Beveridge model was and is universal single-payer insurance. So what this means is that all citizens automatically receive insurance through the government, and this insurance is financed through taxes rather than premiums. So no one has to pay anything to enroll in this insurance. If you are a citizen of the United Kingdom, then automatically you're just enrolled in this public insurance plan. Feature number two is public health care provision. So again, recall that when we're thinking about healthcare provision, we're thinking about providers of healthcare. So these are physicians and hospitals. So in the UK, that has a healthcare system that's based on the Beveridge model, the government decides when and where hospitals will be built. The government then runs the hospitals, and they also run all the clinics. The government decides how many doctors and specialists will be working at each hospital. And then the doctors and the nurses and the specialists and even the managers that kind of oversee the hospitals are all employed by the government. So this is a very government-run healthcare system. The third feature in countries that use the Beveridge model, feature number three is free care. So the idea here is that there's all these hospitals and clinics in countries that use the Beveridge model, and those clinics and hospitals are run by the government. And so the care that's provided at those government hospitals and clinics is free for anyone who wants to go to those clinics or hospitals, because the idea is that the hospital has been paid for through taxation, and people all get their insurance through the government, and the government has all these hospitals. So if you need to go to the hospital, just go to the hospital, and then everything just kind of gets picked up for you in terms of payment. So if you live in the UK and you're covered by this nationalized healthcare, there are no premiums that you have to pay for insurance. There are no deductibles. There are no co-insurances. The one kind of exception to this that I'll point out in case you end up having a trip to the UK and you need to utilize their healthcare system is for certain things, people have to pay out of pocket. So for prescription drugs, for eye care, and for dentistry, people who live in beverage countries have to pay for those things. But for run-of-the-mill medical conditions, they don't pay anything. Like, all of that care is provided to them for free and is provided to them through government-run hospitals by physicians who are employees of the government. Okay, so this was kind of the idea of the Beveridge model. And in 1946, Parliament passed the National Health Services Bill, and that bill established the National Health Service, which is frequently referred to as the NHS. The NHS was a new hospital system that was based on the Beveridge Report, and the NHS went into effect in the UK on July 5th, 1948. So to just kind of help you appreciate what a pivot this was in the UK, at the end of World War II, before they had the Beveridge model in the UK, there were hospitals that were privately run. There were doctors that were not employees of the government. And so when the Labour Party came to power and they kind of used the blueprints laid out by William Beveridge to craft their new healthcare system and make everything entirely public and government run, what that meant was that overnight in the UK, every single hospital was nationalized. And so this was like a huge turning point for the UK in terms of how their healthcare system worked. So the Beveridge model was birthed in the UK in the era after World War II, but it spread throughout different countries of the world. So later, other countries used the NHS as a blueprint in crafting their own healthcare systems. A lot of the countries that adopted the Beveridge model for their healthcare were countries that were kind of somehow tied to the UK. So countries like Canada, Australia, New Zealand, Sweden, Norway, and Denmark have healthcare systems that are in line with the Beveridge model, and they're kind of crafted off of the NHS and what the UK does. Okay, so the goal of the Beveridge model. For countries that choose to have a nationalized healthcare and kind of adopt the features of the Beveridge model, the main goal is for their health system to eliminate most, if not all, of the situations where a patient has to choose between their money and their health. So if you think back last chapter to the 3 circles when we were talking about the healthcare trilemma, what we said is that almost all policymakers, they want health, wealth, and equity, but you can't get all 3 of those things at once. You're going to have to kind of prioritize one of those things over the other. Well, in countries that use the Beveridge model, they have very explicitly chosen to prioritize equity. So the idea is if you live in the UK, it doesn't matter if you're homeless or if you're a millionaire, you can go to the government-run hospital down the street for free. And so rich and poor have equal access to that care. That said, it does come at the expense of wealth and at times health. So the wealth component is that everybody is taxed. So taxes are a lot higher in the UK. In part, that's because they have to pay for the hospitals and they have to pay the salaries of physicians. And then also, in getting this equity, it also compromises health to some extent. And I'm going to talk about that when you turn the page of your class packet. But the idea is because there's a centralized decision maker in the UK that's kind of deciding where to build hospitals, how many doctors to have, what equipment is going to be in the hospitals, that centralized decision maker is going to have to make decisions. And so some things that are available in the United States in terms of like fancy equipment and specialized care, it's not offered in the UK simply because it's like kind of elite and expensive, and the government's not going to pick up the tab for that. And so for some specialized treatments, they're just not offered in the UK. And so if you have kind of a rare condition that needs some kind of specialized care that the healthcare in the UK doesn't cover, it's sad, but you just don't get it. Okay, so again, that's the goal of the beverage model, is we're gonna like, in the UK, they're really gonna just like embrace this idea of we want equity in terms of people's access to healthcare. So what I'm gonna do for both the beverage model and then later the Bismarck model and the American model is I'm gonna kind of lay out the downsides of each of these models so that you can kind of get a balanced view of how they succeed in some respects and they kind of fall short in other respects. So for the beverage model, although it's great when the rich and poor have equal access to healthcare, there are challenges in allocating resources without price rationing. So recall, feature number 3 of the beverage model is free care. That means nobody pays explicitly for healthcare. You don't get a bill from the hospital when you spend the night there. So this means that price rationing, which is something that characterizes most economic models, it just doesn't exist in countries that have nationalized healthcare. Okay, if you haven't taken an econ class for a while, let me remind you of kind of the merits of price rationing. The idea of price rationing is we have a scarce amount of resources in the world, and so we need some mechanism for determining which individuals will get the resources that exist. And so the mechanism that's typically used in most markets is prices. And the idea is that people who really want the good will be willing to pay a particular price for it. For people who aren't willing to pay the price, well, then clearly they don't want the good as much. And so pricing things allows us to kind of distinguish people who have a high want for the product or service relative to people who don't have kind of a high want or need for the product or service. So the question is, if you have a healthcare system where there's no prices, then how do you distinguish between people who really want or need medical care from other people who don't really need it? Because if there's no way to filter out people who don't need medical care and all the care is just being provided for free, then this kind of creates budgetary problems for the government, because they just open the doors to the hospitals. They say, if you want it, come and get it. There's no charge to it. Well, if it's free to everybody, then there's going to be a tendency for people to kind of overutilize healthcare, because the people who need it will go, but then the people who don't really need it, but like, hey, it's free, I might as well go, they go too. And in an efficient market, we don't want all of those people to go because they don't really need it and it's costly to provide the care for them. But again, without price rationing, if everything's free, then there's going to be kind of overutilization of healthcare. Okay, so this is going to lead to a couple of specific challenges that I'm going to highlight. So challenge number 1 for countries that adopt nationalized healthcare is queuing. So again, recall that queuing is, it just means standing in line. It's kind of the fancy British way of saying standing in line. And this is a real problem in countries that have nationalized healthcare systems. Again, the idea is if everything is free, then there's little disincentive for people not to kind of just wastefully go to the doctor on a whim every time they have a sniffle. And so if everybody is just kind of with no breaks in their system going to the doctor every time they have a sniffle, then lines get really long because everybody's standing in line. Like the truly sick people are standing in line for the doctor, and then the other people who really aren't in bad shape, but like why not go because it's free, are also standing in line. And so you just get gobs and gobs of people waiting for care. So to help you kind of understand why this is perpetually a problem, I'm going to give you kind of a head-to-head comparison of how this problem would self-correct in the private market, and then explain why the problem of queuing doesn't self-correct in markets that have nationalized, or countries that have nationalized markets. So let's start with a private market. So as an example, in the private market, if there is a high demand for some kind of medical care, so potentially it might be a high demand for cardiologists, heart doctors, well, then what would happen in a private market where prices exist is the high demand would cause the price of cardiac care to float up because people really want it. So like if you really want it, you'll be willing to pay more and the market price will rise. If the price rises, then doctors' wages are going to increase. If people start realizing that becoming a physician is pretty lucrative because the prices are going up and therefore wages are going up, then eventually the supply of cardiologists will just rise to meet the demand. And so, again, these prices kind of cause the market to self-correct. Again, prices do not exist in nationalized healthcare markets where everything's free. So in nationalized markets, the supply of cardiologists doesn't rise to meet the demand. First of all, because the government is the one that is hiring the doctors. So it's not like people can just say, oh, being a doctor is lucrative, I'll just like open up a clinic. Like the government decides we're going to have X doctors in our country, and then that's a fixed number, and it's not responsive to kind of market forces. And then furthermore, prices don't move, and so that kind of creates extra complications in figuring out how to get supply and demand into alignment. So to summarize, in nationalized markets, supply doesn't rise to meet demand, and prices don't move, and the supply of doctors is regulated. Okay, so the result of this is long lines. And long lines are frequently a problem in beverage countries. If you pay attention to the news, oftentimes this gets publicized that people in Canada or the UK are waiting months and months to get into the doctor. It's a real problem. It's one of the challenges of having a nationalized healthcare system. But again, the upside is it's free. So you can get your medical care for like super inexpensive, but you're gonna have to wait for it, and there's no kind of way for the system to self-correct because prices are not at play. The second challenge that is relevant for countries that utilize the beverage model is the adoption of health technology. So think about this for a minute. So the adoption of health technology is kind of like deciding what health technology is actually going to be provided to the citizens of the country. In the United States, the healthcare that is provided to us, again, is kind of an artifact of what people demand. So we have some like really expensive machines and really specialty treatments that are available, but they come at a premium. That said, if you want to pay a premium price, you can get those things in the United States. In countries like the UK, it's the government that's deciding what machines go into the hospitals and what treatments will be offered to the citizens. And so the government has a budget. They don't have unlimited amounts of money, so they're going to have to make hard choices about certain things are super expensive. We're not going to blow our budget by offering these expensive treatments to people. So, sorry, British people, like if you need, again, one of those really expensive treatments, it might not be covered in the UK. And so this question of like which healthcare technologies to adopt is kind of a touchy subject. So again, I'm going to give you a real quick head-to-head comparison of kind of how things would play out in a private market, which is one you're probably used to, and then think about how this stacks up against a nationalized market. So in a private market, if there's sufficient demand for a new scanner, so like an MRI machine or a CT scanner, well, then the hospital just is free to buy it. Maybe the hospital administrator says, we've got people coming in here with concussions all the time, like we just need another scanner. And furthermore, there's this really fancy scanner that can like get patients through in like 2 seconds. Let's just buy it. In the UK, a hospital administrator does not have that power because the hospital is owned by the government. The doctors work for the government. The government is making all the decisions about what machines to put in the hospitals. And that's it. So in nationalized markets, the adoption of medical technology is just unresponsive to consumers. And it's, again, the government who's deciding when buying things like scanners is a good investment. So I'm going to kind of do a little bit of storytelling here to kind of help you understand exactly how policymakers in the UK make these decisions. There is a group of people in the UK who work for, I don't know if I call it an organization, a center, kind of a group within the government called NICE, NICE. And the goal of NICE is to take every kind of healthcare treatment or service or machine, and for that thing, conduct cost effectiveness analysis. So if you recall from a previous chapter, what you can do is you can figure out by comparing the cost and effectiveness of each medical treatment, kind of how much you would have to pay to get one additional quality adjusted life year. So for instance, maybe you have a scanner and the scanner is good at detecting cancer, and so because it's good at detecting cancer, if you actually buy that machine, it will increase different people's life expectancies, and so you can kind of normalize the cost of that additional year of life and put a dollar amount on it. And cost effectiveness analysis might give you some kind of approximation that would say this machine yields one additional quality adjusted life year at a cost of $10,000. And then the next machine, which is less efficient, will give you an additional quality adjusted life year at a cost of $30,000. Well, what NICE does is they have a threshold price that they are comfortable with. So in the UK, the price that they have kind of decided is agreeable for them in terms of like, we'll cover treatments that generate one additional quality adjusted life year at this price or less. That threshold price is £30,000. So for treatments in the UK that generate one additional quality adjusted life year at a cost of £30,000 or less, the government will adopt those technologies. For the super kind of expensive treatments that are potentially effective, but they're really expensive, well, if that treatment kind of generates one additional quality adjusted life year at a cost of more than £30,000, then NICE says, like, we're not going to put that machine in our hospital. We're not going to offer that service because it's just too expensive relative to what we're comfortable with. And again, the £30,000 threshold is just, it's a number that they have just kind of decided on. There's not like a right price tag. It's similar to me going to the store and deciding like whether I think the pair of tennis shoes that I like are more expensive than I am comfortable with or not. It's just a preference, I guess. So maybe I'm comfortable spending $50 on a pair of tennis shoes, nothing more. That's kind of like the UK saying we're comfortable spending £30,000 to buy one life. We're not comfortable spending anything more than that. So the result of having a centralized agency like NICE kind of making these hard cuts in terms of which treatments they will offer in their hospitals is that, again, if you need a treatment that's super expensive and it's more expensive than what the UK is willing to pay, then you just don't get it. So the result is it might be efficient to let a government adopt just the technology that is cost efficient, but it could also be dangerous if the government underinvests in new technologies. And there are cases that show up in the news every couple of years where there's some patient in the UK, they need some kind of medical help, UK won't cover it, and this is kind of an example of potentially the government underinvesting in technologies that its citizens could actually use. So just to kind of drive this home, this is the note that's on the bottom of your class packet. So in countries that use the Beveridge model, the answer to the question of how much is too much to save a life, well, that's a very subjective question, but in countries that use the Beveridge model, or in countries that have nationalized health care, it is the government who is making that call. So the government is making the decision about how much is too much to save a life. And that's kind of just a hard truth of countries that use the Beveridge model. In the United States, how much is too much to save a life? well, the sky's the limit. If you're super rich in the United States and you want to spend millions of dollars to kind of get fancy medical care, go for it. But in the United States, there's not a lot of equity because the rich can afford better medical care. Again, in countries like the UK where there's national health care, equity is great, but, and here's the big but, this question of like how much will be spent to prolong a person's life is a centralized decision that's made by the government, and so this means that some people who would cost a lot of money to have their life prolonged just aren't going to get the medical care that they might wish to have. Okay, so this is the end of chapter 16. We're going to break for 10 minutes. During the break, if you have any questions about this, I'll try to answer. If you're extra interested in this, another country that uses the Beveridge model is Australia. Australia has a nice kind of spin-off system where they have nationalized healthcare, but then on the side they have like this separate private market where you can kind of like top off your public coverage if you want to like pay extra for private hospital care. So if you're interested in that, feel free to chat that out during the 10 minutes. And then after that, we'll come back for the exercise. for today's exercise, we're going to do something quite similar to what we did last class, in that you're going to be reading an article. But before I set you loose today, I'm going to give you a little bit of background information because the article throws a lot of numbers at you, and I want you to understand where the numbers are coming from. So if you don't have a clean sheet of paper with you, quickly grab one, and I'll try to talk slowly and kind of fill a couple seconds while you get a piece of paper, because writing down these numbers is going to be helpful so that you can reference them as you're reading the article. Background information just as a reminder. So recall from the lecture that currently the UK will provide drugs to people as long as the price of the drug is £30,000 or less for each 1 year of life that it buys. And precisely 1 year of life is going to reference a quality adjusted life year. Okay, for this exercise and for the article, I want you to put yourselves in the shoes of a policymaker who has some budget for spending money on healthcare. And specifically, suppose that the budget for healthcare is £10 million. And then let's just use the threshold price that the UK has said will pay this price to get one quality adjusted life year and the price is £30,000. And then let's think about how many quality adjusted life years could be purchased with £10 million if the cost of one quality adjusted life year was £30,000, or if we were only buying drugs where the price was £30,000 per quality adjusted life year. Okay, so think about £10 million spent on that drug that costs £30,000 per quality adjusted life year. If you spend £10 million on that drug, then you could buy 333 quality adjusted life years. Okay, recall that this threshold price of £30,000, it's very subjective. So it's just the number that the UK has said we're comfortable paying that for life. It's not like a right or wrong number. There's nothing magic about £30,000. They're just saying, okay, we would spend this much to save a life because that's just the number we're comfortable with. So what the article is going to grapple with is, should they change that threshold price that they're comfortable with? So it's kind of like the policymakers saying, should we be willing to buy kind of drugs that are more expensive, or should we be more stingy in terms of like not paying for certain drugs that are expensive? So to kind of help you understand why this is a debate, let's think about what would happen if the UK changed the threshold price that they're willing to pay for life, and they lowered it so that they only would pay for drugs, for example, that would buy them one quality adjusted life year at a lower price of £20,000. Okay, so suppose the approved acceptable price was moved to £20,000 per quality adjusted life year. The policymaker, they've got these £10 million to spend. If they spent those £10 million on drugs that bought them one quality at a price of £20 million, then with their budget, they could buy a full 500 quality adjusted life years. So the intuition here is that the more stingy they are in terms of like, we're not going to pay more than X for life, the more life they get with a fixed amount of budget, or with a fixed budget. Suppose they became even more stingy. So suppose the approved acceptable price was moved to £13,000 per quality adjusted life year. So in other words, what if the government said we're only going to pay for drugs that give us one quality for £13,000 or less? Well, with that fixed budget of £10 million, if they're only buying the drugs that give them one quality for £13,000, then they could actually buy a full 770 quality adjusted life years. The argument that's typically made by just people who are talking about these things is that the reverse should be true. So the typical argument is that like the UK is too stingy in terms of the drugs that they cover, and that the UK should be more generous and they should actually provide their citizens with expensive drugs. So let's engage that thought. Let's say that the UK raises their threshold for what price they're willing to pay for drugs, and they set their threshold price that they're willing to pay for an additional quality at £50,000. So suppose the approved acceptable price is moved up to 50,000 pounds per quality adjusted life year. And then they've got this fixed budget of 10 million pounds. Well, with those 10 million pounds, if each drug that they buy gives them one QALY at a price of 50,000 pounds, then they would only be able to purchase 200 quality adjusted life years. Okay, here's where you're gonna definitely need to write things down. So in the table here, I just have kind of an array of different scenarios. And so this is to help you understand, at different kind of acceptable price points, like what would materialize in a country. And I'm choosing these specifically because these are some of the numbers that are referenced in the article. So this will hopefully be helpful for you to kind of understand where they're coming up with these numbers. So column number 1 of the table is an approved acceptable price. So these are just, again, hypothetical situations where in the first row, the UK says we're only going to give people drugs if the drug buys us one QALY at 13,000 pounds or less. The next row is the UK becomes more generous. They say we'll only provide people drugs if the drug buys us one QALY at 20,000 pounds or less. And then the next row is what their current threshold is at 30,000 pounds. And then the last row is them being generous and saying, we'll give our people a drug as long as it gives us one QALY at 50,000 pounds. Okay, the second column is basically the numbers that I showed you previously. So the second column is the QALYs that 10 million pounds would buy if the price tag is the various levels that are shown down the rows. Okay, the last column is going to be the number of QALYs lost relative to if the approved acceptable price were 13,000 pounds. Okay, the idea is kind of the most stingy situation I've given you is the UK saying we're not going to buy drugs for anybody unless the price of the drug is 13,000 pounds or less for a QALY. So the more generous they become, effectively they're actually giving up some QALYs as they become more generous. And so the last column, it's going to say as the country becomes more generous, as they start paying for more expensive drugs, how many quality adjusted life years are they forfeiting in exchange for providing people with more expensive medical treatment? Okay, so now what you actually need to do. The assignment is read the article. The article is Patients Suffer When NHS Buys Expensive New Drugs, says report. There is going to be a health economist that's referenced in the article. His name is Carl Claxton. He makes a particular argument that the government should stop spending money on drugs that cost more than 13,000 pounds for each one QALY they get you. And then there's going to be another guy who kind of offers a rebuttal. His name is Sir Andrew Dillon, and he makes the argument that the government should spend money on the drugs that cost more and are kind of expensive. So what I want you to do is think about Claxton's argument that the government should stop spending money on drugs that cost more than 13,000 pounds per QALY versus Sir Andrew Dillon's argument that the government should spend money on the drugs that cost more and are kind of expensive. And then what you need to turn in is consistent with the last little blurb on the screen. I want you to describe which person you tend to agree with and why. This is not a right or wrong answer. This is kind of just to help you think through, if I was a policymaker in a country that had nationalized health care and I was the person in charge of making decisions about whether I was going to cover expensive medical treatments, where would I come down on this? Would I come down on being kind of stingy for the sake of kind of buying more QALYs with my budget? Or would I come down on the side of being more generous in terms of like letting a few people get like really expensive treatments, but by letting few people get really expensive treatments, I'm kind of like burning some money. So in aggregate, the country's going to buy less QALYs in total. One final thing, and hopefully this helps you just kind of internalize the trade-offs here. This is kind of the picture that's going on in my mind when I'm thinking about kind of the arguments that are being made in the article. So on the left and the right, there's two groups of people. This is kind of like the population in the UK. The idea is if you give somebody medicine, it extends their life. So the arrows are kind of consistent with how much it's extending your life. Okay, what's typically true is that the drugs that are cheap, or kind of give you a big bang for your buck, are drugs that provide incremental increases in people's life expectancies, but you can give them to everybody. And so if you give everybody a small incremental increase in their life expectancy, then in total, you get a whole bunch of additional qualities in aggregate. What is often the case for drugs that are really expensive is that they're really expensive because they're like brand spanking new, they've just been developed, and they're for something very specific, but they're really good. And so if you kind of offer people these drugs, well, then the few people who have this like rare condition will have their lives saved. So it's like a huge increase in their life expectancy, but it's only a few people and it's really expensive. So this is sometimes the tension. What is sometimes true is that the cheap drugs prolong a whole bunch of people's lives incrementally, whereas the expensive drugs like really materially impact a handful of people. So they like save the lives, but they save the lives of just a few people. So again, this is one of the trade-offs here. Like, would you prefer to have aggregate qualities maximized, in which case you would maybe opt for something consistent with the left picture, where you only cover cheap drugs and everybody gets a small little nudge in their life expectancy in total, like you add up all the little nudges and you get like a big change in aggregate life expectancy? Or would you rather kind of cover expensive drugs, which in aggregate aren't going to increase total additional lived years as much, but for a few people, like it really makes a big difference in their own personal lives. Okay, so if this last picture doesn't help you at all, ignore it. It's what goes on in my mind. Once you have kind of described where your own position is on this, and again, I don't care what your position is, I just kind of want you to think about it for yourself. That will be it, and I will see you back for the next class.